Hi, I'm Dr. Jared Gardner. I'm here today with my resident, Dr. Iman Sarami, and we're doing a bone and soft tissue elective unknown set number 2. And I'll get these slides scanned and put online. So wherever you're watching this in the future, look down in the video description to see links for the slides once I get them up. All right, so Iman, this is a 35-year-old who's a recent mother. She just had a baby and has a 6-centimeter abdominal nodule. So this area right here, skeletal muscle here. So here's what's happening. This is skeletal muscle, but the muscle's actually getting entrapped by the tumor.
Oh, I see.
Yeah, it's really kind of interesting this is a really important point, is that these entrapped muscle cells can cause a variety of problems. Number one, they can mimic muscle differentiation or rhabdomyoblasts occasionally. Also, when they get caught up in the middle here, sometimes they get really tiny and their nuclei begin to overlap.
Like atrophy.
Exactly. That's muscle atrophy, and good job picking that up. That is such an important thing to recognize in all parts of soft tissue, because sometimes muscle atrophy can look really weird and bizarre and can mimic pleomorphism. You can imagine if these nuclei overlap a little bit more, that could make you think of a pleomorphic cell, and then you might start thinking this is a sarcoma or something like that. So what the actual lesional cells here are, and there's more muscle atrophy right there. So these cells here are the lesional cells, and we can see that they're running in fascicles. So they're all going the same direction here, and they're all going the same direction. They're all parallel to each other, and they're spaced out from each other mostly. A few of them touch here and there, but most of them have space in between, and the space between them is filled with collagen. And we can tell if we go down closer and we flip the condenser, you can see there's actually little fibers in between, right?
Yeah.
So the collagens in between, the cells themselves actually have their own cytoplasm that's not pink, but actually this kind of purple color, kind of lavender or amphiphilic sort of cytoplasm. So that feature there of having this kind of bluish purple cytoplasm in spindle cells, and then collagen in between, is the hallmark of fibroblasts and myofibroblasts.
Yeah.
So this is a spindle cell proliferation composed of fibroblasts or myofibroblasts, which I think of as kind of like existing on a spectrum. And the cells are very bland. They run in fascicles, but they're not cellular. They're really hypocellular, have a lot of collagen in the background. And these fascicles are huge. Look, we're here at 4x, and you can see the fascicle starts down here, and it goes and sweeps all the way across, and it keeps going, right? It just goes across the whole screen. So and it's like a giant highway. If you have a highway and all the cars are going parallel to each other, and it's like 100 lanes wide and like 150 miles long. So it's just like a ginormous highway of a bunch of fibroblasts all running parallel to each other in nice orderly fashion. So that is the characteristic. These sweeping hypocellular fascicles of fibroblasts or myofibroblasts is the characteristic feature of desmoid fibromatosis. So this is a desmoid tumor. And when we're really lucky, we'll see on the sample this entrapment of skeletal muscle. So this tumor is locally aggressive. It's an infiltrative tumor, but it does not have metastatic potential by our current understanding. And but it really can cause some problems because it can grow into normal structures. It has a high rate of recurrence when it's excised. And when I was in training, there was still a tendency to do wide local excision on these. But over the past 10 years or so, I've seen this trend in a lot of places. They choose to not excise them, and they treat them with different types of medical therapies like tyrosine kinase inhibitors, and sometimes can really stabilize or even shrink the tumors down. So, but diagnostically, what we're looking for is this broad sweeping fascicle pattern. And sometimes people see these fascicles and it's pink and they think smooth muscle. And it's not smooth muscle, though, because of what I showed you at high power. The cells don't have pink cytoplasm. They have bluish purple cytoplasm. The pink is actually collagen. And if you look at smooth muscle fascicles, the whole thing is pink because the cytoplasm of the cell is packed full of contractile filaments. And look here, this is another little pearl just to remember. Anytime we have fascicles, if you cut a fascicle longitudinally, it'll look like this. But this stuff right here is the same exact thing as this. It's just cut in cross-section, and instead of being long, thin cells, the cells look round because they're coming out of the screen at us. So it's a good thing to remember, and this is, I know you probably know this, but for any beginners watching this, that the three-dimensional part of pathology sometimes is tricky because things cut a different way can look very, very different under the microscope. So just kind of like if you took a sausage or a hot dog and you cut it long ways, it'll look like a spindle cell. But if you cut it in half to make like little slices for like a little baby to eat or something, maybe not a little baby, but anyway, you're supposed to cut up hot dogs, I guess. Then they look round though when you cut them up. So anyway, I don't know if that works. Maybe I'll edit that out later, or I'll leave it in and then people can laugh at me. That'll be fine. But the intrametal skeletal muscle is really characteristic, and it exemplifies the infiltrative growth pattern that these tumors have. So these tumors are myofibroblastic. They will, or again, we talk about them as like fibroblastic, SMA, but they often have SMA. Typically, Desmoid is negative, actually, but there are some exceptions. I've seen a fair number of these that have scattered Desmoid, and even a couple I saw that had quite like a lot of Desmoid, but the way they looked, they just looked they looked incompatible with the smooth muscle tumor. So I have seen them have a lot of Desmoid, but I would say as a general rule, expect that Desmoid's usually going to be negative here. But myofibroblasts sometimes do have some Desmoid expression, so it can sometimes have that. The other thing, these tumors are driven by beta-catenin. So nuclear beta-catenin is what the classic test question answer is. And in real life, I find beta-catenin can be really challenging to interpret because it often has a lot of cytoplasmic staining, which is totally non-specific. The only thing that matters is seeing the nuclear stain. And sometimes the cytoplasm has so much stain, it's hard to tell if the nucleus is staining. Although I have seen times where it really worked, but I used to say I never use beta-catenin because it ends up causing more confusion than it's worth. But I have seen some times where it was helpful. But don't expect it to always be easy to read. I've seen some classic desmoid tumors that it was really hard to find good nuclear beta-catenin, even though it was clearly a desmoid tumor. And I've also seen times where stuff looked like it had nuclear staining, but it was actually not desmoid tumor. So, here's some hemorrhage in it, and sometimes you can get myxoid change and loose like tissue culture. This particular example doesn't have that. So sometimes you can get kind of nodular fasciitis looking areas in desmoid fibromatosis. So this one's growing into the muscle, and they are also, particularly the ones in the mesentery, they are sometimes associated with familial adenomatous polyposis. And so the APC gene that's abnormal in that, the APC gene, normally its gene product breaks down beta-catenin, and when it's inactivated, then beta-catenin builds up into the nucleus and then makes the tumor grow. So that's how desmoid fibromatosis works. And if you're watching this, I've got a full video about desmoid tumors that kind of goes and shows some other examples. I'll try to remember to put a link down below. Okay, case 2. It is a 50-year-old male with a 15 centimeter, that's 15 centimeter retroperitoneal mass. Looking at this tumor here, it looks like mature fat mostly, kind of like you'd see in a lipoma, but there's a lot of extra stuff. There's pink in between the adipocytes, and you'll notice that the adipocytes, even from low power, they have a variable size. You can see that you've got big, large ones, and you've got kind of some medium-sized ones, and then little tiny smaller ones. So there's variable size, and then intervening between the adipocytes is abundant pink collagen. Sometimes it's kind of strands like this. Other times it can be really homogeneous and very sclerotic and packed together. And then you're already probably noticing, what are these guys? Big, hyperchromatic, atypical pleomorphism scattered around in the midst of this. And so what I've just described for you is the characteristic triad that you want to see in well-differentiated liposarcoma, also known as atypical lipomatous tumor, depending on where it occurs. In this case, we have a retroperitoneal mass. We call it well-diff liposarc. If it's in the extremity, like in the deep muscle of the thigh, which is probably the most common place that I see it, or if it's in like the superficial soft tissues on the outside of the trunk, which you have to make sure with imaging that it's not internal, then you call it atypical lipomatous tumor. And if it's in the groin, like right around the paratesticular region, we call it well-diff liposarcoma in that location. So why the different names if the tumor is otherwise the same? Well, the difference is that these behave differently. If they're in the retroperitoneum or the inguinal canal area, paratesticular region, they often recur again and again because it's very difficult to eradicate them surgically. Whereas if they're in the extremities, they have a much better prognosis and they can usually be removed with negative margins and have a lower risk of recurrence and a very small risk of de-differentiation into high-grade D-diff liposarc, where in the retroperitoneum that risk is much higher. So again, what I've described for you is the classic features, and not every case, though, is going to follow this pattern. This is a really nice, very characteristic example of well-differentiated liposarcoma / atypical lipomatous tumor. But in some cases, you can have ones that are much more lipoma-like and composed of mature fat with very little of this sclerotic collagen, these collagen or fibrous bands. You can sometimes have very little of that. Also, sometimes the atypia can be very focal, or even in rare cases can be completely lacking. So if I see a tumor that looks like a lipoma, but is really large, like bigger than 10 centimeters, I tend to usually like to do MDM2 FISH. So the characteristic molecular finding in well-diff liposarc atypical lipomatous tumor is amplification of the MDM2 gene, as well as other genes that live in that same region on the long arm of chromosome 12. So that's MDM2, CDK4, and a handful of others. But the most common one that I usually test for is MDM2 because that's the FISH that I have available. Now, there are immunostains for MDM2 and CDK4. I just find them more challenging to interpret, but I know some really great soft tissue pathologists who like them, and some people use them as a screen, that if they're negative, then that's a good sign that it's not well-diff liposarcoma. If they're positive, then you can proceed to FISH to help confirm it. In a case like this, the clinical history of a large mass in the retroperitoneum and the microscopic findings are just classic, and I personally would sign this case out, and in fact, I think I did sign this out on H&E alone with no special stains, no FISH or anything. So in any case, you do, of course, as always, have to make sure that it all makes sense. Now, one thing you may notice I did not talk to you about yet is lipoblasts. And that's because lipoblasts, although they may be seen in well-diff liposarcoma, they are not required for the diagnosis. If you have the features I just showed you, that's the characteristic feature, the big atypical pleomorphic cells. That's the key cell that you want to find to point you towards well-diff liposarcoma, these hyperchromatic guys here. There are, right there, are scattered lipoblasts in this case. You can't really see a pleomorphic nucleus very well. It's kind of crunched on the side, but you can definitely see vacuolated, multi-vacuolated, clear lipid-filled vacuoles in the cytoplasm. So some cases will have lipoblast. They can be scattered or they can even be abundant. But other cases will totally lack lipoblast, and that's absolutely fine. There's some more little bubbly lipoblast for you there. Not nearly as pleomorphic in this case as you might see in some tumors. There's a couple other vacuolated cells there. But you do not have to have them for the diagnosis. Now, I have a whole long video all about liposarcoma 101 that goes into great detail about all the variants of this tumor, well-diff liposarc, and also other liposarcomas like myxoid liposarcoma and pleomorphic liposarcoma. There's some nice lipoblast. I mean, everyone likes finding a lipoblast. It's very satisfying to find them, and they're pretty intriguing to look at visually. Let me get a better view for you. But just remember that they're not required. I've seen people send in a case of where they think it's a well-diff liposarc, and they've got dots all over, like 20 different slides on this huge mass, and they're dotting little bubbly cells that they're like, could this be a lipoblast? And right there, all over, are these big hyperchromatic pleomorphic cells, which again, that's the hallmark cell. That's the cell that is the classic cell that I'm looking for to make a diagnosis. These hyperchromatic guys here. And something that Dr. Weiss taught me in fellowship, she said, you know, they're so densely hyperchromatic that when you try to focus up and down, the chromatin's so dense that you can't see through them. And I find that pretty helpful. There's sometimes exceptions, like that one has kind of pale chromatin right there with the two nucleoli. But a lot of times I do find they have this very smudgy, dark hyperchromasia. And why that's helpful is that in some cases, fatty tumors can have fat necrosis. Both benign and malignant fatty tumors can have pockets of fat necrosis, and the histiocytes in pockets of fat necrosis sometimes overlap, and their nuclei can mimic the hyperchromatic cell of well-differentiated liposarcoma. And I saw an area earlier. Let me go back and look for it. Oh, and I will point out also before I go on is look at this, how dense and sclerotic that collagen is. That's real characteristic of the fibrous bands that you see in well-differentiated liposarcoma, atypical lipomatous tumor. There's more of the hyperchromatic cells in the background. And the hyperchromatic cells do tend to like kind of hang out by the blood vessels. So if you're looking at a fatty tumor and you're seeing some sclerotic stuff but can't find atypia, and it's a large mass and you're worried about it from the clinical perspective, then go hunt around the blood vessels and see if you can find any of the hyperchromasia in the collagen-rich areas right around the vasculature of the tumor. That can be a helpful hint sometimes. Another tip that I gratuitously stole from my wonderful mentor, Sharon Weiss. So, oh, there's another lipoblast. Sorry, I really am interested in liposarcomas, so as you can tell, I get very distracted when I look at them. But there's a nice lipoblast there. And I am going to try to find those histiocytes. I saw them while we were scrolling around. So look, right here is a little cluster of histiocytes with bubbly vacuolation. And that's just a pocket of fat necrosis. You can see that in regular, more or less normal subcutis that's just been traumatized or that's had a procedure done nearby. You can see it in a lipoma with fat necrosis, which is a common microscopic mimic of well-diff liposarcoma. People see those histiocytes and they get worried. But right here, the characteristic cell, that's the atypia of well-diff liposarcoma. These guys right here, just histiocytes. And look, they have relatively kind of paler chromatin. It doesn't always work. This one has a little bit of bean-shaped nucleus too, but I feel like under the microscope when you look, they usually look a little different. The histiocytes tend to have more fine, delicate chromatin. These ugly guys, the pleomorphic cells of well-diff liposarc, tend to be more hyperchromatic, smudgy, kind of chunky, grungy looking chromatin. But if I have a hard case where I can't tell, if I'm like, there's a little atypia, am I sure? Is that enough? Then I just do FISH. And FISH is a very sensitive and specific test. FISH for MDM2, very sensitive and specific test for well-differentiated liposarcoma versus lipoma or other benign mature adipose tissue. Now, it can be seen in some other tumors like intimal sarcomas, cardiac sarcomas inside the chambers of the heart, also low-grade central osteosarcoma, which is weird. Like, why do those tumors that are totally unrelated to well-diff liposarc, why do they have MDM2 amplification? Who knows? Molecular answers some questions for us and then opens up a whole bunch of new ones that we don't have full understanding of yet. So, again, a very characteristic example. And oh, there, right there's some multinucleated. Those are histiocytes right there. That's just fat necrosis, this little pocket right here. So if I just had that, I'd say, no, that's just fat necrosis. But it does take a little practice, so I encourage you, look down below. I'll have the digital slides for these up eventually once I get them scanned. And you can spend some time studying this slide to really get a feel and tell apart the areas like that, which are fat necrosis, from the true hyperchromatic pleomorphic cells like these guys here, which are representative of well-differentiated liposarcoma. And again, MDM2 will help you out immensely if you have a mature fat lesion where you're not sure if you're dealing with a well-diff liposarcoma or a benign mimic. And again, check out that Liposarcoma 101 video down below, and you can learn a lot more about liposarcomas. So, well-differentiated liposarcoma, aka atypical lipomatous tumor. Let's see, number 3 is a 24-year-old with a slow-growing hand mass. Let's see what we have here. Okay, we've got a large mass of something, multiple nodules here. Okay, do you have any ideas about this particular case?
I have one that because the cells look very epithelioid.
Yep.
And like putting together with like the sarcoma looking for proliferation. And like necrosis and like it's a malignant tumor probably. So I went with the epithelioid sarcoma.
Very good. This is indeed an epithelioid sarcoma. And from low power, they can have different types of patterns, but they have a tendency to make nodules deep down in the subcutis or even down near the fascia. They often grow. The classic form of epithelioid sarcoma, it typically presents as a mass on the distal extremity of a young adult, is the kind of classic, scenario, although I've seen it in other settings. And they tend to make these nodules that have central necrosis, and sometimes they can be less cellular. This one's pretty cellular and scary looking even from low power, and it's got a lot of inflammation. But sometimes when they're not very cellular, that necrosis in the middle can make them mimic palisaded necrobiotic granuloma, like you'd see in a rheumatoid nodule or deep granuloma annulare. And the cells can kind of look histiocyte-like sometimes. Again, though, when you get close here, usually, even on those that look a lot like rheumatoid nodule from low power, when you get closer, you're like, ooh, those cells look bad. They are huge cells. Yeah, they all have mites. They're really big and atypical. They tend to have this kind of pale, cleared out chromatin like this. See, sometimes they have like this kind of very pale vesicular looking chromatin, kind of a grayish color. The cytoplasm is usually this dense pink cytoplasm because they are filled with keratin filaments. So they look epithelioid and they stain with keratin because they're filled with keratin filaments. So because of that, they almost have that kind of hard cytoplasm that you see like in a squamous cell carcinoma. But to me, I think cytologically, sometimes they have some resemblance to squamous cell carcinoma to my eye. I don't hear people talk about that very often. Although you're not going to, get a, how old was this patient again? I can't remember. What did I say? They're young though, right?
24.
Yeah, 24-year-old's not going to get a nodule of squamous cell carcinoma in their subcutis, right? That just doesn't make sense. So, in any case, this is epithelioid sarcoma, and there's a variety of different epithelioid soft tissue malignancies that can come into the differential with this, and that's kind of a little outside the scope of for just one video, but and a lot of the epithelioid, the sarcomas that have epithelioid features, a lot of them stain with keratin, which is particularly frustrating and problematic. So these tumors also have loss of INI1 or SMARCB1, SMARCB1. In the vast majority of cases, there are some rare exceptions that have an alternative, a SMARCA4, I think, or BRG1 that can be lost. I don't think I've seen one of those yet that I know of, but in any case, these tumors will have INI1 loss usually, and so the nuclear INI1 is usually expressed in the nuclei of most nucleated cells in the body, and the tumor cells will have loss of that, but the background cells will stain. So you'll still see it in inflammatory cells and endothelial cells. And it's not a specific marker. There is a growing list of other tumors that can also have INI1 loss, but in this setting where you have this look, and it's the distal extremity of a young person, and it stains like an epithelioid sarcoma, the INI1 loss can be helpful to confirm it. And these tend to be relatively aggressive tumors. They kind of metastasize up the extremity, kind of in a sporotrichoid, like how sporothrix, grows, that kind of pattern, and they can metastasize the lymph nodes. So they're kind of weird. They break a lot of the rules that we think of for normal sarcomas. And thankfully, they're quite rare, but they are very problematic for the poor patients who get them. And it tends to be young people and sometimes children even who get it. So it's a really bad tumor. And you could, if you see the blood, you could think of epithelioid angiosarcoma, which can sometimes have some similarities in staining. For example, ERG, which is a great marker for vascular things, but it stains about half of epithelioid sarcomas. CD34 tends to stain epithelioid sarcoma. CD31 should be negative. So there are some other, you sometimes have to do a broader panel on these to exclude other things in the differential. But that is a good one to remember. So I try to remember anytime I think I've got a rheumatoid nodule or a deep granuloma annulare, I always ask myself, is there any way it could be epithelioid sarcoma, in the hopes that I won't make that mistake? Because I've seen some that were really close mimics. And so I just try to make it a habit to ask myself that. And of course, most of the time, granuloma annulare and rheumatoid nodule are so much more common than this very rare tumor. But I try to always keep that in mind so I don't make that mistake. All right, case 4, we got a 60-year-old man with a leg mass. Lots of myxoid here. So there are adipocytes in there, and I think that these are probably actually background fat with myxoid stuff in between. Yeah. Sometimes a problem in soft tissue pathology, particularly with fat, is it's really hard sometimes to tell if fat is part of the tumor or if fat is being entrapped by the tumor. And there are certainly many times where I still struggle with that and think, well, it's hard to be sure sometimes. But here I think that
fat is not a part of the tumor.
I think in this case, I think the fat is trapped and kind of infiltrated by the myxoid stuff.
I thought it's like a myxofibrosarcoma.
Well, that's exactly what it is. Good job. You've got myxoid, very infiltrative growth. And if we go look around, even though it's not super ugly from low power, it's very hypocellular. When we look around, we begin seeing scattered, hyperchromatic, atypical cells. So there is atypia here, and by definition, to make a diagnosis of Myxofibrosarcoma, I'm trying to get it in focus here, you have to have at least some atypia. Like you need to have some hyperchromatic atypical cells or pleomorphic cells scattered in the myxoid background, usually with these kind of prominent elongated vessels like we're kind of starting to see right here. You get these long vessels that people call curvilinear. They're kind of these long vessels that snake through the myxoid background. And then in the midst of that, you have these scattered pleomorphic cells. So when it's very low cellularity like this and you just have the scattered pleomorphic cells, I would call that a grade 1 Myxofibrosarcoma. You could also say low-grade Myxofibrosarcoma, but I don't like to do that because it sounds a lot like low-grade fibromyxoid sarcoma, which of course is totally unrelated. And if any of you out there are frustrated by those very confusing names, I'm with you. I understand that it's frustrating, and I actually have a short video on my YouTube channel that shows how to differentiate Myxofibrosarcoma from low-grade fibromyxoid sarcoma pretty easily. But this is a very good example of Myxofibrosarcoma, which has pleomorphism, must have pleomorphism. So myxoid background, prominent kind of curving, elongated vessels, scattered pleomorphic cells. As it begins to get higher grade, as it gets into grade 2, I don't have an example right here, but the cells will start to clump and cluster together along the vessels. And then grade 3 will have sheets of stuff that looks like high-grade sarcoma, like UPS. It'll have solid areas that look like that, and then other areas that'll be loose and myxoid. And the important thing to remember about Myxofibrosarcoma is, number one, it is actually relatively common as sarcomas go. I mean, all sarcomas are rare, but this is much more common than many of the other types of sarcoma. I see this regularly, sometimes several times a month. I may see Myxofibrosarcoma. It usually is on the extremities of elderly people, and about half of the time it arises above the fascia. That means in the dermis or subcutis. So it'll show up in derm path and in other areas where people are maybe not expecting to have a sarcoma. It can grow in the deep muscles too, but it has this tendency to involve the skin. And many sarcomas grow and push everything out of the way, but this is a sarcoma that's very infiltrative. It oozes with all that gooey myxoid blue background. It oozes in between. So you can see it here getting in between some fascia, and there's some sweat coils down there. It's growing and oozing in between, and it spreads along the subcutaneous septa, spreads along the fascia, and because of that, the surgeons, even experienced sarcoma surgeons, sometimes really have trouble clearing this tumor. They'll cut way around the mass, and the margins will still be positive. So because of that, it has a high rate of local recurrence. And even though this grade 1, the very low grade ones, they do not usually metastasize, but when they recur, they can become higher grade over time, and then once they're higher grade, they can metastasize. So again, just the scattered pleomorphism in the background and all of the myxoid change. Oh, that was the one other thing I was going to show, is they have these bubbly cells like this.
Pseudolipoblasts.
Yes, these are pseudolipoblasts. They have vacuoles, but the vacuoles are not like the nice sharp circumscribed ones like we saw in the true pleomorphic lipoblasts. And also, even though it's a little hard to tell, it washes out a little on the video recording, it's got a little bit of bluish color in the middle rather than clear or white space. It's the same color as this background, and that's because this is a tumor cell that has sucked up that hyaluronic acid myxoid background. And here's another one over here. Here's another one down here. And this is a common thing. You can see it in other sarcomas with myxoid change, but it's particularly characteristic of Myxofibrosarcoma. And I think I even saw, if I recall over here earlier, I saw a better one, and then I got distracted talking about vessels or something and forgot to point it out. Well, that one was good enough. But yeah, pseudolipoblast is a common finding in Myxofibrosarcoma. So good, important sarcoma to be aware of. And no, unfortunately, no specific immunostain pattern here. It's pretty much based on just the appearance of it and the clinical situation. And some other tumors, like for example, liposarcomas, can have Myxofibrosarcoma-like areas. Like pleomorphic liposarcoma can have myxoid areas that look just very similar to that. D-diff liposarc can do the same thing. So there are other tumors that can sometimes mimic this as well. Okay, so number 5 is a 20-year-old female with a 2-centimeter neck mass.
schwannoma, like
Good.
A and B and
Yeah.
body.
A very nice one. You're right. This is a great example. Trying to get the slide clean here, of schwannoma. And this one is particularly nice because you can really see the hypercellular Antony A areas, which sometimes become quite cellular. See, look at this, like almost fascicles here. So there are times that you can get so much cellularity in the middle of a schwannoma that people can sometimes get concerned for malignancy. Usually you don't have very many mitoses in schwannoma, although there's sometimes it can be exceptions. And here you can see right away the palisading, right? So the palisading in schwannomas we call, of course, Verricae bodies. And what that means is that the nuclei are all piled up or lined up together on one side and on the other. And in the middle, there's this empty space that's just filled with pink collagen. So sometimes the Verricae bodies will be really dramatic and nice, like in this case. But also other times the palisading in schwannoma can be very subtle. And so recognizing subtle palisading is a really useful clue for schwannoma and other nerve sheath tumors and some other tumors like spindle cell lipoma and things like that are not neural but tend to have palisading. So just recognizing sometimes that in a spindle cell lesion, if there are areas where the cells all seem to be kind of clustering together and then other areas they don't cluster as much. I mean, this is palisading. This is palisading in here. This is a little Verricae body. Let me see if I can turn the light on. Yeah, it's still a little bright. Maybe I'll turn it down. Ah, that's better. Okay. So that's the palisading and the Verricae bodies in the Antony A areas. The other thing you see in schwannomas that's really useful, and it's really good to learn all of the features, not just the palisading, because sometimes schwannomas don't have Verricae bodies or have very subtle palisading. So that's when having the other clues can really help you, especially on a partial biopsy. Hyalinized sclerosis around vessels, really useful clue. Schwannomas tend to have this prominent reactive sclerotic kind of change around the vessels. See, like right here, even these small vessels. See how sclerosed that is? So the hyalinization of vessel walls, because see, if you just had this picture here, I mean, these spindle cells don't look particularly specific. I mean, to me, they look kind of neural, but I think a lot of people might look at that and wonder what it is. There's vague palisading in here, a little bit of lining up, a little bit of lining up of nuclei, but you and maybe are wondering if I'm making that up, right? And I bet a lot of people at home are like, yeah, right, that's not. But the palisading here is very, very subtle. It's certainly not a nice textbook Verricae body. So sometimes getting spindled stuff like this with a hyalinized vessel, and then look over here, foamy cells. So in the Antony B areas, you get loose, kind of foamy or frothy looking cells. You can get areas that are edematous. So the Antony B areas are the hypocellular areas. And you can see them out here. You can have myxoid change. You can have stuff that looks kind of like neurofibroma with like kind of the shredded carrot type of collagen sometimes you see like that. That looks a little bit like neurofibroma to me. Not exactly, but a little bit. So the Antony B areas are loose and kind of less specific looking. But here at low power, you can nicely see both the hypercellular Antony A, the hypocellular Antony B, and also look at that nice thick capsule around the outside, a thick fibrous capsule. And that's because schwannomas arise out of the nerve and they grow and push outward from the nerve. And so what happens is the perineurium gets pushed along with it and it gets kind of fibrotic and sclerotic around the edge. But a lot of times if you do a perineurial marker like EMA or GLUT1 or Claudin1, you don't have to do this. But if you happen to do one on a schwannoma, you'll see a layer of perineurial cells in this outer capsule oftentimes, which is kind of evidence that it's arising from within a nerve and pushing it out. So, and then of course schwannomas are made of Schwann cells, so they're going to be diffusely strongly positive for S100 protein and SOX10. Although most of the time you don't actually need stains, you just look at it, and once you know what a schwannoma looks like, it's usually an H&E diagnosis, although in a small biopsy or in an unusual case, immunostains can be really helpful to confirm. All right, so that's schwannoma. And there's a little bit more kind of a swirling Verricae body areas down there. Oh, and sometimes they can have a lot of hemorrhage. So not only do the vessels get hyalinized, but sometimes they leak, and you can get a bunch of blood-filled areas and hemosiderin in the middle of the tumor, and that can sometimes cause confusion, make people think it's a vascular tumor or something. So obviously S100 will solve those problems really easily. Okay, let's see number 6. A 42-year-old male with a leg mass, and clearly we got a huge slab of tumor here that's just been cut out. So this is obviously a large, deep mass. If it was big enough that we could cut a whole square of tumor out, and it is a collagenous, very pink, and although the other thing is pink, sometimes you can think of muscle, but if we go down to closer power here, higher power, we can see that in between the spindle cells, there's actually fibers, little tiny collagen fibers that we can see, little threads of collagen. So that tells us that what we're dealing with is actually something that's making collagen. So probably fibroblastic or myofibroblastic, or maybe you could think of neural also, but probably not smooth muscle. And here the cells are very bland. Look at that. So bland and benign looking. Let's see if I can get it in focus. They just like have almost no atypia, no pleomorphism. It's very hypocellular, no mitoses that we're seeing. Let's go back to low power. There are some branching kind of staghorn vessels, like you can see in solitary fibrous tumors. This area here is very pink. Over here, it seems to get a little bit more cellular. Still not very cellular, but there's kind of a variability that some areas are a little more cellular, like this, and other areas are less cellular, more kind of hyalinized and sclerotic. And then, let's see if I can still find areas. This is a little bit of an old slide that's beginning to get washed out. But these areas here have a little bit of bluish myxoid background. The blue is a little harder to see on this slide because it's a little older. So we've got kind of a pink collagen-rich tumor that's got a little bit of myxoid area, has some areas that are a little more cellular and others that are a little less cellular, and very bland nuclei. So any ideas what this might be?
Fibromyxofarcoma?
Yeah, this is low-grade fibromyxoid sarcoma, also known as Evans tumor, after Harry Evans, who first described it in the 1980s. And these tumors are real important to know that they're relatively rare, but they're deceptively benign appearing. They are sarcomas, but they don't have any of the features that we usually associate with sarcoma. Pleomorphism, necrosis, mitoses, all that stuff. They lack that, with rare, very rare exceptions, but usually they look so benign. They look like a neurofibroma, like a perineurioma. Maybe sometimes they can swirl and look a little like a DFSP, solitary fibrous tumor. They can look like a lot of those things, but they don't usually look malignant. So recognizing that variability in the collagen-rich and sometimes more myxoid. This one doesn't have very much myxoid change at all. And then also seeing that some areas are a little bit more cellular. Even still, they're not like sheets of cells. They're still spaced apart by collagen. And then other areas are very hypocellular and like kind of sclerotic collagen like that. That's the key. And then you can use an immunostain, MUC4, MUC4. MUC4 is going to be positive in this tumor. And it can stain a few other things, but overall, when it looks like this, it's a very specific marker in the proper histologic context. And there is a molecular abnormality between the FUS gene and the CREB 3L1 or 3L2. Just remember FUS, CREB, and that's enough to remember. That will be positive. But now that we have MUC4, I usually don't need to test the molecular. When I see the pattern and then the MUC4 expression is usually enough to make the diagnosis. So that's low-grade fibromyxoid sarcoma. Really important tumor because it can mimic a lot of benign things, and you don't want to mistake that. I have a full-length video about this on my YouTube channel if you want some to see other examples. Okay, case 7. This is a 40-year-old female with a 3-centimeter mass arising from the posterior cervical spinal nerve root. And you can already see, wow, look at all that pigment. Really, really dark, abundant pigment, even from low power. If we look over at the edge here, there's kind of a dense fibrous tissue around much of the lesion. But over here, if we go in closer, we'll go look at the lesion in a second. It helps you orient where we are. We're actually not only in the nerve root, but actually out in the ganglion. And you can see the background that has that neural appearance, and scattered around in here are large ganglion cells. So this tumor is arising from the nerve root, kind of pushing out next to the ganglion. And now let's go look at the tumor itself. It's composed of kind of sheets to fascicles of these atypical, large, kind of epithelioid to spindled cells with very very prominent nucleoli. You can see these large nucleoli here. Oh, and I forgot to mention, Iman had to step out to go to sign out, so that's why he's not chiming in anymore. But you can see these large atypical cells, and there's abundant brown pigment, and this pigment is actually melanin pigment. So when you see kind of atypical, ugly-looking cells that have large nuclei and have abundant cytoplasm, and they're making melanin pigment, well, guess what? That looks an awful lot like metastatic melanoma, doesn't it? But a 3-centimeter metastasis of melanoma to the cervical spinal root with no history of melanoma and no other lesions present, is that possible? Well, I suppose so. Melanoma can do anything, but that seems awfully unlikely, right? So in that case, when you think something looks kind of like metastatic melanoma and stains like metastatic melanoma, but it's arising from a spinal nerve root, the tumor that you should think of is this one, malignant melanotic nerve sheath tumor. Now that is a tumor you may not have heard of before because it's a relatively new name. In the older days, like when I was in training not that long ago, these were called melanotic Schwannoma or psammomatous melanotic Schwannoma because they do have some overlapping features microscopically with Schwannomas, but we now recognize that they really are a different tumor with a different behavior. I'm going to point out here, because someone's going to ask once they look at the slide, there are all sorts of vacuolations here that really look an awful lot like lipoblastic type cells. There are all these vacuolations. I don't know. I assume these must be lipid droplets because they're clear and indenting the nucleus, but I'm not as sure what the significance of this is. Maybe someone out there can tell me. Maybe it's been described before and I just overlooked this feature in one of the papers. I've only seen a small handful of these tumors, and each one has looked a little bit different, but they all keep in common the fact that they're producing melanin pigment and have these kind of spindle to epithelioid cells. Some of them, like this one, look very ugly and have huge nucleoli and look quite a lot like melanoma, but I've seen other ones that were a little bit more bland and monotonous and uniform cellularity and were a bit more spindled and not as epithelioid as these. So they can really range between spindled cells and fascicles to more epithelioid cells in these kind of diffuse syncytial sheets where it looks like all the cytoplasm from each cell is blending together to make kind of a sea of cytoplasm. So they can vary, but they often, the production of pigment, which is usually present, it seems, in the ones I've encountered at least, that can really help tip you off. And the spinal nerve roots are the most common location, but they've been described in a variety of other locations, including the GI tract, skin, soft tissue, bone, I think maybe the liver, if I recall correctly. So there's been, like everything, eventually people will describe them in all sorts of weird locations. I think in those other locations, you have to be really careful to make sure you've excluded metastatic melanoma. That's an important rule here. And in the past, we really didn't have too much to do because if you stain these tumors, they stain like melanoma. They stain with S100 protein and SOX10, and usually with a variety of melanocytic markers, including HMB45 and MART1 or melan-A, whichever name you like. So those things that's not going to really solve the problem for you. It's a tumor that's making melanin and stains like melanoma. Okay, so now we know, though, that these tumors usually have loss of a gene called PARKAR1, P-R-K-A-R-1. PARKAR1A, actually, is inactivated. And that is the gene, if you remember from medical school, that's the gene that's involved in Carney complex, a germline inactivation of PARKAR1A, which is in about, I think, half or so of Carney syndrome, or Carney complex, excuse me. I don't know that it's in every case, but it's a gene that's highly associated with Carney complex. And this tumor, which has a tendency to arise in the setting of in patients with Carney complex, this tumor has loss of PARKAR1A. So you can either prove that by showing PARKAR1A mutations molecularly, or you can do the immunostain, which shows loss of expression of PARKAR1A. So now that we know that and have an easy test for this, it's very helpful that if you're having a debate between malignant melanotic nerve sheath tumor and metastatic melanoma, that you can send and have the test for PARKAR1A done to see if the tumor is lost. And both patients with Carney complex can have that loss, but also the majority of the tested cases that have occurred sporadically in patients without Carney also have loss of PARKAR1A. And so my fellowship director in DermPath, Doug Parker, said the way to remember the PARKAR1A for Carney's is you park your car in the garage. Park for PARKAR1A, and CAR for CARDI. So sometimes those little mnemonics can be really helpful. That's helped me, and I've remembered it all these years later. Now, there's one other feature I wanted to point out to you before we talk a bit about behavior, and that is the old name of this, like I said, is psammomatous melanotic Schwannoma, and that's because they make melanin, and they have some kind of neural, some Schwannian-looking features microscopically in some cases, not so much this one, but look right here, and I wish I could show you. It's hard to show up on the camera, but hopefully you can see this little calcification here with little rings of lamellated rings here. So that's a psammoma body. Now, the bad news is that these psammoma bodies, while they're really great when you find them, I can't recall ever seeing a melanoma with psammoma bodies. I've seen quite a few melanomas, but I suppose it's possible, and maybe if you do a literature search, you'll find someone that's described it, although I would be really hesitant to accept that unless they've done the PARCR1A test on the case. But in any case, I don't think I've ever seen psammoma bodies in a melanoma, but they are not always present in malignant melanotic nerve sheath tumor, aka psammomatous melanotic Schwannoma. About half of cases will have psammoma bodies. As you can see, there's multiple right here, 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 here. So very nice example, but some cases lack them. About half of cases have them and half don't. I think there was another focus around here that had even more, actually, but those were pretty good. So you can check out the digital slide once I have it scanned. I'll put the link down below and really explore this case for yourself. So what's the point of renaming this tumor? In the past, it was called melanotic Schwannoma, and now we're changing the name to malignant melanotic nerve sheath tumor. It's also been referred to, at least in one paper, as malignant melanotic Schwannian tumor. Well, the reason is that these tumors do not behave like Schwannomas. Schwannomas are totally benign and indolent and extremely rarely can show malignant transformation, but otherwise they're benign. But this tumor, a subset of them behave in a malignant fashion and an aggressive fashion like a sarcoma. And in some papers, the rate of the metastatic risk in these tumors is around 15%, but other studies have shown it to be as high as 45 or 44%, excuse me. So it really runs a range from the different series. And particularly when you look out at patients, so you follow them up over 5 years or longer, in patients that are more than 5 years out from their original diagnosis, only about half of patients are disease-free. So it seems that this is a tumor that, despite initial thoughts that it could behave indolently most of the time, a significant subset of patients, maybe even up to half of patients over the long term, can have aggressive behavior and metastases and have a behavior that's similar to a sarcoma. So that's why now it's important, and I think when I've made this diagnosis in practice, I've mentioned in my report in the comment that this has been called psammomatous melanotic Schwannoma in the past, but it's important to recognize that these tumors actually do not behave like Schwannomas, and they do have a potential for malignant behavior and need to be treated and managed accordingly. So I think that's the important thing to take home here, is to remember that they are not like regular Schwannoma, and it's important to distinguish them from metastatic melanoma, either clinically or by testing for PARCR1A, and then also to check if the patient has other features that might suggest that they actually have undiagnosed carni complex. And so that is an example of a very rare tumor, and this is a really, really characteristic example of that tumor. So hopefully you will have learned from this and enjoy the chance to see something very rare. And oh yeah, there we go. See, there is a little bit of palisading there. It's vague, it's not like perfect K bodies or anything, but you can appreciate that the cells are kind of lining up in rows here. The nuclei are kind of lining up side by side in little parallel arrays, and then there's little zones in between of pink that don't have as much. So that's where the idea that these maybe were some sort of a Schwannoma came from originally, that they do have areas sometimes that look kind of Schwannoma-like. But over time, and even with molecular studies, I believe Andrew Fulp's group did a study where they looked at melanomas and Schwannomas and then these tumors, and they found that if you do a gene profiling study, these cluster in a different area away from melanoma and away from Schwannoma. So they're not totally like Schwannomas and they're not totally like melanomas. They're kind of their own thing, which seems to make sense since they have a unique behavior that's different from both of those tumors. Okay, case 8 is a 15-year-old male with a lesion of the distal femoral epiphysis. So the end of the long bone right underneath the cartilage, and we're actually seeing cartilage here, which may represent part of their growth plate. It's hard to tell because at low power, you can see we've got a curetted specimen, curettage fragments multiple fragments of mature cartilage here, which I'm going to tell you does not represent part of the lesion. This is background cartilage. I imagine that they scraped out the lesion and that it was right near the edge of the growth plate, and that's where this cartilage came from. And then in between, we've got these fragments of lesional tissue, abnormal tissue. It's not bone and not regular cartilage. And they're just kind of a diffuse sheet of uniform mononuclear cells. They don't have much atypia. They all kind of look the same. And if you go closer and look at their cytology, let's see if I can get it in focus here. You can see that some of them have nuclear grooves, these kind of elongated lines here down the length of the nucleus. And some of them have a kind of vaguely bean-shaped or reniform, kidney-shaped nucleus. So these kind of grooves and bean-shaped, coffee bean-shaped, some people like to say, cells, that of course is the buzzword for the tumor that we're looking at here, which if you're at home, you're hopefully shouting out the answer right now. And then also some scattered giant cells, commonly seen in this tumor and in many other bone tumors for that matter. But the thing you're all waiting to see is this, right? The ultimate buzzword, the chicken wire calcifications. So, and also if you shouted out Langerhans cell histiocytosis because of the bean-shaped nuclei, that's not a bad idea. The nuclei of this tumor, which is chondroblastoma, can look similar to Langerhans cell, but in Langerhans cell you'll have eosinophils and mixture of the background inflammatory cells, and then the usually radiographically going to be a bit different. So these tumors here, this is chondroblastoma, which is a benign tumor of cartilage. And here what happens is the chondroblasts don't develop into well-formed mature cartilage like the cartilage we saw over here, the mature background normal cartilage, like from the growth plate here. You can see the chondroid cells are arranged into these kind of rows, right? These columns, these tall columns, which is typical of what happens at the growth plate. So that's their background normal cartilage for comparison. But this tumor doesn't usually make much normal cartilage. Sometimes it has some pink kind of chondroid areas. Sometimes it can begin to get a little bit chondroid here. And in these areas, it makes this purple lace-like or chicken wire pattern calcification, which you can see. And oftentimes the areas like this, the cells are kind of degenerated or even dying. And that's when they get wrapped around with this purple chicken wire calcification. So that's a very good example. Now, I have seen chondroblastomas that did not have good chicken wire calcification. So if it otherwise fits well for this, that's okay, I think. But I've seen some that I thought otherwise fit well for chondroblastoma but didn't have this. But this is the characteristic feature that if you're lucky, you'll get to see. And then radiographically, the patients are going to usually be skeletally immature. Not always. This can occur in adulthood, but usually it's in teenagers to young 20s. Oftentimes the patients are skeletally immature, and the lesion will be a well-demarcated lytic lesion in the epiphysis, often on the end of a long bone, and they'll have a nice sclerotic rim around it, a sharply demarcated rim, which kind of indicates slow, benign growth. Now, that's all very loose interpretation of radiology from me, a non-radiologist. So if you're a radiologist watching this and I misspoke, please forgive me and correct me in the comment section, because obviously radiology is much, much more nuanced than I begin to understand, even as a bone and soft tissue pathologist. But that's a really nice chicken wire calcification. And then again, you're going to have sheets of these bean-shaped or coffee bean grooved nuclei in the background, often scattered giant cells like here. And that can actually lead people sometimes to mistake these and think it's a giant cell tumor because there's multinucleated giant cells and mononuclear cells in between. And that could resemble a little bit giant cell tumor of bone. So giant cell tumor bone tends to occur more in adulthood in skeletally mature patients, whereas chondroblastomas are usually in skeletally immature patients. And in giant cell tumor bone, you're going to want to find areas that have diffuse sheets of large osteoclastic giant cells, usually with many nuclei present. Now, when you get a fragmented or partial sample, it can be more challenging, and that is something to take into account. But when they're a kid, I'm pretty reluctant to make a diagnosis of giant cell tumor of bone. In any case, I always try to think of all these other things first. I don't know if I've ever seen a giant cell tumor bone in a child, but I'm sure it's happened, but I don't think that I've ever seen one personally. So you can spend some time exploring this slide once I have the digital slide up, and I'll have the link down below, of course, and you can check it out for yourself. But this is a very nice example of chondroblastoma. And let's see if there's any other areas here to to talk about. Here's another one of those kind of areas where the cells become degenerated. You can see they're kind of like smudgy and breaking down, and then that's when they become calcified, and you get this chicken wire calcification. Oh yes, this case doesn't really have it, but these tumors often develop secondary aneurysmal bone cyst areas, so they can get areas that look like ABC. So if you see an ABC from a child, look around and make sure there's no areas with sheets of chondroblasts. That would indicate that maybe it's a secondary ABC arising in a chondroblastoma. So let's see, one of the questions here we have is what are the other bone tumors that are usually epiphyseal in the epiphysis? So I just said a giant cell tumor often is a lytic lesion in the epiphysis of a long bone, but it tends to be in adults. In kids, we have osteoblastomas as seen here. Aneurysmal bone cysts, so they can occur in a variety of locations. They can occur in the epiphysis of long bones. And then finally, a very rare entity, but one that tends to be in the epiphysis also, is clear cell chondrosarcoma. And I've got a video about that. I'll put a link down below, and you can go check that out. A very distinct appearing tumor. It's extremely rare, but it's an important tumor to know about because it can mimic some other things. It doesn't look like a typical chondrosarcoma, and it also has a different prognostic implications. It tends to, in general, have better prognosis than some of the other forms of high-grade chondrosarcoma. So here's another look at those coffee bean-shaped nuclei in this very classic example of chondroblastoma, a benign tumor. And the majority of these are treated successfully surgically. I believe they often will curette them out, and occasionally, though, they can recur, but they are benign. Okay, case 9. Now we have a 40-year-old female with a finger mass. And even without the history, you can figure that this is probably from an acral site. When you have a circumscribed nodule that's kind of popped out without much tissue around it, maybe a little fat, maybe a little dense regular connective tissue like tendon or tendon sheath, like we're seeing a little probably bit of here. And then right next to that nodule, if you see that, a nodule that's popped out with not much around it, usually it means you're from the subcutis. And on top of that, if you end up seeing these structures here, which are one of my favorite structures, probably my favorite normal structure in the body, Pacinian corpuscle, is a deep kind of pressure and vibration sensors that are most abundant on the ventral surfaces of the distal extremity, particularly like in the wrist and the hands and fingers. So this was from the finger in this case, but those beautiful little onions there are Pacinian corpuscles. You could occasionally see them in other sites, but that's the most commonplace. And then here, look at that. We've got eccrine sweat ducts or glands or eccrine coils. So in the acral sites, the palms or soles, you tend to see, you'll see a deep nodule that's down at the level of almost the tendon sheath, and at the same time you can see skin structures because there's not very much space there between the epidermis, and the epidermis to the bone is only maybe a centimeter or so in some areas on acral sites. So you'll see these skin structures like the eccrine coils, and then you'll also see a nodule that's maybe attached to the tendon sheath or something like that. So that's a good clue when you see Pacinian corpuscles to think of acral sites. When you see a nodule that looks like it's subcutis or even coming off of tendon or fascia, and then it's got eccrine coils or eccrine sweat glands, whatever name you like, that's a good thing to think of the fact that you're probably coming from acral or a site nearby. All right. We have this nodule. It's arising. You can just barely see a little bit of tendon sheath here, but it's coming off the tendon sheath or off the fascia. Sometimes in the hands, all those dense regular connective tissue can get kind of blend together. I don't really always know how to tell them apart unless the surgeon tells me what they are. And here we've got a tumor with a lot of different stuff going on. We got a circumscribed nodule, very sharply circumscribed. We have areas with kind of dense collagen with kind of a cracking artifact in this case. We've got abundant foamy histiocytes or xanthoma cells, whichever name you like. And you can see they're foamy because they have little clear, that's a little hard to show on the scope here. But if you look, foamy cells actually have little tiny clear vacuoles in them. That's how you can tell them apart from granular. You should see little tiny clear bubbles that are filled with lipid. Very tiny, and they will sometimes indent the nucleus of the cell. It's hard to tell that here. They don't always do that, but you look for little tiny vacuoles and bubbles that are clear. filling the cytoplasm. That's what you want to see for foamy histiocytes. So we got foamy histiocytes, sclerotic collagen. Oh, we also got some hemosiderin deposition here, some pigment that's chunky and golden, and when I flip the condenser, you can see it's very refractile. So that's characteristic of hemosiderin. Look at these cells right here. So these cells have this large kind of pale nucleus with a large nucleolus, and then abundant eosinophilic kind of dense cytoplasm, kind of pink to gray or maybe purple even here, a little amphiphilic if you like. And this one has a little ring of hemosiderin around the outside. I hope you can appreciate that. Maybe I'll flip the condenser to show you. Yeah. See, there's this like kind of little dusty ring of hemosiderin around the outside. And the nucleus is off to the side. It's eccentric. So this is kind of a plasmacytoid, or I kind of almost like to think of them as rhabdoid-looking cells. They're like kind of histiocytic looking, but also have an eccentric nucleus. There we go. I bumped the slide. All right. And then look, a couple more of those cells here, each of them having this peripheral ring of hemosiderin. So these are the characteristic cells that you want to see for this tumor. So this is a tenosynovial giant cell tumor. And it could either be giant cell tumor of tendon sheath, which is tenosynovial giant cell tumor localized type, or if, and we've seen already from low power, this is a circumscribed localized lesion. So that's certainly what this is going to be. And it's also in the finger, which is a good location for that. But if it looked like this at high power, but say it was a diffuse infiltrating mass in the knee involving the joint space, then we would say it's tenosynovial giant cell tumor, diffuse type, also known when it involves the joint space, the synovium, also known as pigmented villonodular synovitis. So I've got a whole video about those two entities going into great detail. I'll put a link below. But in any case, it's good to remember that they are basically two variants of the same tumor. Tenosynovial giant cell tumor at high power, they look identical. They have all the features we're talking about here. The difference is one of them is circumscribed and usually smaller, tends to be more in the distal extremities. And the other one tends to be more diffuse, infiltrative, often involves the synovial space of large joints like the knee, and tends to be more locally aggressive and problematic for the patient. Even though it's technically benign, it can really cause a lot of morbidity for the patient. So the distinction is based on the clinical and radiographic features. If I just have a fragment, I'll call it tenosynovial giant cell tumor. And then in the comment, I'll say it could either be the diffuse or the localized type. It totally depends. You have to correlate radiographically or correlate with the intraoperative findings, something like that. So what I want to see, though, are these plasmacytoid histiocytes that have an eccentric nucleus. If you're lucky, you'll see this ring of hemosiderin, which I find a very characteristic finding for this tumor. And then look, they often have mitoses, sometimes many mitoses, and they can be very scary to see these large, plump, epithelioid-looking cells and then find mitoses everywhere. So you may notice I'm talking about something that's a tenosynovial giant cell tumor, or a giant, oh, I forgot to mention, the other name, the localized form of tenosynovial giant cell tumor is also known as giant cell tumor of tendon sheath, which is what this is. So I talked about giant cells, but where are the giant cells? Well, what's important is to remember how to diagnose this with all of the features that are not giant cells, because some cases lack giant cells, or the giant cells may be very sparse and very focal and hard to find. So in those cases, if you don't recognize all the features we just talked about, then you're going to potentially make a misdiagnosis when you see these big plump cells here, and then you start finding mitoses. And if you haven't already thought of giant cell tumor of tendon sheath or tenosynovial giant cell tumor, then you can really get into big trouble there and make a mistake. You think it's malignant or something. Now here are some scattered osteoclastic, usually osteoclastic giant cells. That one looks almost like a Teuton giant cell, but they're usually osteoclast form. And they can be abundant, or they can be totally absent, or sparse and focal, like I just said, and scattered around the tumor. There's another mitosis. Like I said, sometimes the mitotic rate is quite high. Very scary. And they tend to have this very dense background collagen that's so sclerotic, looks almost like osteoid. Sometimes they can calcify. I have not encountered that very frequently, but some of my bone and soft tissue colleagues tell me they see that regularly. And there again is the characteristic, the neoplastic cell, these plasmacytoid histiocytes. There they are. Sometimes they're binucleated, and when they have that ring of hemosiderin, I like to say they have a halo, like an angel, like a halo of hemosiderin. But I believe that some others have called them ladybird cells, like which is like the British word for ladybug, I believe, which is, if you haven't seen one of those, you can go Google it. There, I guess that's kind of like a ladybird cell. Looks like a little ladybug because it's got, like, you know, those two little round fake eyes that they have on top. Okay. And then the foamy histiocytes I find quite helpful. It's not always present, but I'd say in a significant subset of cases, you will have, maybe even a majority of cases, you'll have some area of foamy histiocytes, although it may be focal. It tends to be more around the periphery of the tumor, like kind of a zone out at the edge. So go look out around the outside. I find it really helpful to find the foamy histiocytes. And then also hemosiderin usually present at least focally. So you may have to hunt around for those things, but it can really help you out if you're having a tough case and not sure of the diagnosis. And also sometimes you'll get little pools of discohesive tumor cells where they're all kind of falling apart. Not seeing that so much in this one. This one looks actually very, very sclerotic. And maybe it's been around longer, hard to say, but I kind of wonder if it's been sitting here kind of sclerosing over time. But that's just me using my imagination. I can't prove it. But if you want to see some of those other features, like I said, go check out the video down below, and it'll show you some of the other variations on this theme. These are relatively common, and because they can be mitotically active and can have few or no giant cells, it's really important for pathologists to be aware of these. They also tend to be, sometimes are PET avid. They can be hot on a PET scan because they're mitotically active. So I've seen these before incidentally discovered, both the diffuse and the localized type. I've seen them discovered incidentally on a PET scan or a PET CT in a cancer patient who was getting worked up with PET CT, and then they found this hot nodule on PET, and then on biopsy you see these big epithelioid looking plasmacytoid cells, and you see mitoses. And I've seen a case like that on frozen section where it was really tempting. They said the patient has a history of cancer, and this is a PET hot nodule, and these cells look large, and then there's mites. And then I saw some hemosiderin, and then I saw some foam cells, and I was like, ooh, wait. I think this is actually tenosynovial giant cell tumor. Let's defer to permanent. And sure enough, that's what it was. But it was really tempting with that, all those history points there, to make me think, you know, maybe it's metastatic carcinoma. And there were no giant cells on the biopsy on that one. On the excision, there were a few. So in any case, it's an important thing to keep in mind and to remember. And that was something that Mark Edgar, one of my awesome soft tissue mentors, told me, that some cases can be PET avid. And I'm so thankful he told me that, because when I encountered one in practice, I was able to thankfully not mistake that for malignancy at the time of frozen section. So hopefully that pearl will help save some of you in practice. And again, spend time studying. Don't just stop at the giant cells. When the giant cells are present, it's easy, but spend time learning all the other features. So next time you see one of these, go look around, see if you can find one of these little cells with a halo of hemosiderin. They're not always there, but oftentimes you'll find them, and they're very satisfying and very pretty to look at, I think, too, to my eye. So go and hunt around and explore the background and learn all the subtleties of this tumor so that you can recognize it when it's not classic microscopically. All right, finally, case number 10. It's a 70-year-old male with a leg mass. Let's see where we are. Oh, here's skin. I'll turn it around. So we've got a tumor that's going all the way up into the dermis and also is infiltrating way down into the subcutis, kind of multi-lobulated. You can see there's multiple lobules here. And even from low power, you can tell there's a lot of empty space in there, or pale space. And this slide's a bit older, so it may just be a touch washed out. But this is actually a blue myxoid material, or in dermatopathology, for the derm-trained folks, often will call this mucin. The path-trained people will often call this myxoid. It's the same thing. It's ground substance, hyaluronic acid, whatever you like, okay? So there's a bluish material here, and again, I find that mucin and myxoid stuff tends to fade first on an H&E slide. It doesn't take long. Some slides like this one that are only a few years old begin to already have fading of that kind of myxoid background. So there's myxoid material dividing the tumor cells. There's multilobulation, and there's a lot of heterogeneity. We have hypocellular areas here with low cellularity cells scattered in this mucinous background, myxoid backgrounds, and then zones here that are really cellular and like a solid sheet. Now let's go down and look at them cytologically. Oh yeah, before we do that though, notice what else is here. Look at these parallel lines running through here. These are all blood vessels. These long vessels that kind of run along, and as they run, they gently curve and undulate. See how they're kind of curving back and forth as they go? So we call these curvy linear vessels. And I've mentioned before in other videos, but the vascular patterns of soft tissue tumors I find to be relatively subtle, and it was one of the last things for me to really I think, grasp as I finished up my fellowship. Even as I entered practice, I still was learning the nuances of recognizing vascular patterns. So if you have trouble recognizing all these curvilinear and hairpin and chicken wire and all the different vascular patterns, staghorn, all the stuff people talk about, don't feel bad. I feel like that some of that stuff is quite subtle, and it took me a while to pick up on it. So you're not alone if you struggle with that. But over time, those vascular patterns, if you can pick up on them, do become quite helpful. Look what we can see here. We've got tumor cell necrosis already, where the cells are turning all pink and the nuclei are dying. And it doesn't, even from low power, you can tell these are ugly cells, very hyperchromatic, pleomorphic, big, huge nucleoli, all the nasty stuff, big, ugly pleomorphic spindle cells in a myxoid background with long, elongated, kind of dilated, curvilinear vessels, and it's arising in the dermis and subcutis on the extremity of an elderly patient. So all of those are buzzwords when put together that make a diagnosis of Myxofibrosarcoma. So this is Myxofibrosarcoma, and based on the presence of these sheet-like areas that basically look identical to what you'd see in an undifferentiated pleomorphic sarcoma, UPS, when you have sheet-like areas that look like that, and then other areas that are more loose and hypocellular and myxoid, then I'll call that Myxofibrosarcoma high grade or grade 3, okay? And then the low-grade ones should just be scattered atypia in a myxoid background without much significant cellularity, and in between you can call it grade 2, although I find that most of the time I do that when it's a partial sample or a biopsy. I'll say Myxofibrosarcoma, at least grade 2 on this sample, and I feel that a lot of times once those come out, they often end up turning out to be grade 3 in some area. These tumors tend to be heterogeneous. They can have areas that are very hypocellular and others that are very cellular. So when it's a large mass and you're getting a needle biopsy and it's myxoid and a little atypical, I will often even mention that in my comment, that myxoid tumors tend to be heterogeneous, and therefore sampling variation on a small biopsy can be a much bigger concern with myxoid tumors in particular. Sometimes correlating with the scan can be helpful because radiographically on CT and MRI, the musculoskeletal radiologist is often able to say, oh, there's areas here that are cellular, there's areas that have more of a myxoid quality, that look kind of myxoma-like, but other areas that look, higher grade and cellular, and there's some necrosis and hemorrhage. So they'll often even be able to tell you, oh, this is a very heterogeneous tumor. But the problem that I encounter is that a lot of times these tumors are on the smaller side, and because myxofibrosarcomas, about half of them occur above the fascia, like this one's do. It's occurring in the subcutis and even into the dermis. So they often get misdiagnosed clinically as a cyst or a lipoma, as so many different superficial sarcomas and other tumors often are thought to be cyst or lipoma because they're just a flesh-colored bump, and those cysts and lipomas are super common, and these things are rare. But as sarcoma, all sarcomas are rare, but as sarcomas go, myxofibrosarcoma is actually relatively common. I probably see a couple, 2 or 3 cases maybe a month and in my practice. And in the past, when I used to take consults, I saw them even more often than that. So as opposed to some other tumors, like say the similarly named but unrelated tumor, low-grade fibromyxoid sarcoma, also known as Evans tumor, I see that maybe 1 or 2 times per year. So there are some sarcomas that are, all of them are rare compared to common types of cancer, like colon cancer or breast cancer. But among sarcomas, some are rare and some are ultra rare, and then everything in between. So this, again, is important to keep in mind because you might get a shave biopsy off of one of these. I've gotten multiple of these where they're shelled out in a chunk and they thought it was just a cyst, and their pre-op diagnosis was cyst, and the post-op diagnosis was not a cyst. And then all I get is big chunks and fragments of tumor that looks like this. So I've seen all different variations on that theme, and I do feel, though, that these have a higher tendency to get misdiagnosed as something else and then to get sampled kind of partially or, not receive a definitive cancer type surgery up front because they don't look like they're going to be a sarcoma clinically. As I like to bring up to my dermatology residents, this is an important sarcoma to know about because among sarcomas it's relatively common and it often occurs in or right under the skin. Okay. So these tumors, this one is a relatively small one, but they oftentimes infiltrate along the subcutaneous septa and also along the fascia, and because of that, they can really extend far beyond what appears to be the clinical boundary of the tumor. So they'll do a wide local excision, and oftentimes the margins are still positive, way out beyond where the tumor looked like it was limited to the naked eye and to palpation. So that's a really important thing, and to make sure that your cancer surgeon is aware of if they're doing resection. And sarcoma surgeons are very familiar with these, and I feel like the sarcoma surgeons and orthopedic oncologists I've worked with are often frustrated by these tumors because they'll go do a wide margin and still end up dealing with positive margins, even though they thought they were well around it. So it's a very vexing, frustrating problem for the treating physicians and for the poor patients who have to endure these tumors. So these, when they're high grade, they do have potential to behave in an aggressive fashion and not only recur locally, but metastasize. When they're purely grade 1 and superficially located above the fascia, at least in some studies, they have essentially no risk of metastasis at that point. But if they recur, they do have a tendency to kind of increase in grade and progress into a higher grade as they recur. And then, of course, they develop the potential to metastasize. And if you have trouble remembering how to tell apart Myxofibrosarcoma from low-grade fibromyxoid sarcoma, because the names are maddeningly similar in the sound, I do have a video that's like 5 minutes long and will help make it really clear to you that these are very easy to tell apart. They are not lookalikes, they are name-alikes. They sound similar, but almost never do they look like each other, with very rare exception. Okay. And I do have a full-length video about both low-grade fibromyxoid sarcoma and this entity we're looking at here, Myxofibrosarcoma, and I'll put those links below as well. Now, one last thing I'll point out is that Myxofibrosarcoma and some other myxoid tumors, like myxo-inflammatory fibroblastic sarcoma, another tumor that's frustratingly similar in name and can actually look quite similar to Myxofibrosarcoma. I have a video and a whole slide image example of that I'll link below as well. But the point is that myxofibrosarc and myxo-inflammatory fibroblastic sarcoma, both of them have a tendency to suck up the mucin or the myxoid material from the background and make these blue kind of loose vacuoles in their cytoplasm. And those are called pseudo-lipoblasts. Do not confuse these with true lipoblasts, which would, if this tumor had a true lipoblast, I would call this not a myxoid liposarc, but I'd call it a pleomorphic liposarcoma with myxoid change. And I have a whole video about liposarcomas, Liposarcoma 101. I'll put a link below. You can check it out. All right, so anyway, myxofibrosarcomas often have pseudo-lipoblasts, which are bubbly mucin-filled or myxoid-filled tumor cells. All right, we've really hit on all of those points. And again, you can go watch the longer video if you need some more information. There's some ugly pleomorphism there. But this is Myxofibrosarcoma. Be on the lookout because you will probably encounter this tumor at some point during your career, maybe even multiple times. And again, I'll put the links online once I get them scanned. Thanks so much for watching. I hope you found this useful. Have a great day.